This morning's episode, we are going to be joined by Bart, who you see there, and George McGoughlin. What we're going to try to do is give you everything in about a half an hour. We're going to have first our wonderful interview with Rob. Then we'll do some quick hits on some widely covered news stories. And we'll follow up with a couple of less covered news stories that we think deserve some discussion between myself and George. And then we'll take some questions and answers. So let's get right to our interview with Rob. Rob, welcome. Thank you very much for joining. And excuse me, I forgot to introduce George. George is Director of Solutions Marketing for Redox. George, welcome. And George, you're joining us from Wisconsin. How is it out there?
We're just getting to that point of end of summer, early fall. Thanks for having me, Jeff. Excited to learn more from Dr. Bart today, and everybody in the chat. Thank you for joining us.
And so, it's going to be a great show. Rob is the Chief Medical Information Officer at UPMC. Rob is formerly the Chief Medical Officer at Cerner. Rob is just a font of information. And Rob, the first question is, I know you're originally from Hawaii. Anybody impacted at all by the fires on your end? And we send all our thoughts and prayers out to the people that are dealing with that, and just wanted to make sure everybody on your end is fine and safe.
Yeah, so thank you for asking, Jeff. I do have my mom and brother's extended family in Hawaii. My mom has some second and third cousins that are on the island of Maui, but they were up on what's called on the somewhere the upper land on the side of Haleakala, which is the large crater there away from Lahaina. So fortunately, they're all okay. I had the fortune, one of the last trips I took pre-pandemic in the November of 2019, I spent some time in Lahaina, and so many memories, not just as an adult, but as a child growing up in Hawaii and traveling to the outer islands. Beautiful place, beautiful people. And knowing a lot of the people there, I know that they'll be able to recapture that at some point as they recover from this tragedy.
Yeah, it looks, like an absolutely gorgeous place. And, obviously the natural resources will take some time to recover, but hopefully, some of the man-made resources we can, help them rebuild. So thank you for taking your time, and I hope you give our best to everyone there. So Rob, one of the things I wanted to get to is, there's a tremendous amount of hype around ChatGPT, generative AI. And when you and I were doing the prep call, you talked about people, being able to spend hundreds of millions of dollars on ChatGPT and coming out with nothing, in terms of healthcare, at least. So, could you kind of elaborate on that thought as a starting point?
That comment sort of came actually from a conversation with UPMC's CEO, Leslie Davis. We had gotten onto the topic of artificial intelligence and talking about creating governance for our healthcare system. And I reflected on a few other sort of technologies that were emerging into healthcare. One experience I had related to sort of, virtual imaging devices with goggles, that there seem to be almost more companies out there than surgical specialties, and they're all sort of pushing their platform. And as I thought about this in a broad sense, not just for generative AI, but for AI in general, if we didn't bring it into the organization in a thoughtful manner, that there was so much hype out there that you could spend $50 or $100 million and not have any practical improvement in either efficiency or care delivery within your organization. And that's what really sparked the conversation about creating a governance infrastructure, which is still an evolving conversation here. But I think it's at least allowed many of our leaders to sort of pump the brakes a little bit and be a little bit more contemplative as we think about how artificial intelligence could enhance care delivery in the US.
And as you look at that, and as you create the governance infrastructure, how do you help ensure that what you're doing is right for your population as opposed to something that may be more generalized or not as customized to the population that you have there at UPMC?
I think that, so that's a key question, Jeff. There are starting to, as many of our audience knows, there are many companies that are generating algorithms. And so we'll contemplate sort of the non-generative, but sort of traditional, what I would say more traditional artificial intelligence. And I think it's very clear that regardless of how good someone's existing algorithm is, it still needs to be localized to the patient population or your population that you're delivering care to. For example, I have some very knowledgeable, inventive colleagues here. We have our own sort of homegrown risk of readmission score that we've embedded within our electronic health records. When we compared with some of the scores that are in the public domain, it was clear that the generation and localization of our score based on our patients provided higher value in being instructing and guidance and care delivery than those that you might get a little bit more off the shelf. And so that really pointed to the value of, even though someone shows you a score that has high predictive value, for example, it still needs to be tuned to your patient population, and you have to adjudicate whether that predictive value still persists.
Right. And how do you kind of in practice go ahead and do that? It's one thing to kind of put the policies in place, but how do you then take that and, as you mentioned, talking to your CEO, and then bring that into working fashion with your clinicians and people in your IT organization?
So in that instance, we've got a very strong clinical analytics team here at UPMC. Is headed by Dr. Oscar Mariquin, and you need a team that's nimble and has a good clinical understanding of the data that you're trying to interrogate and utilize. Make sure they have access to it, understand the provenance of the data, because that's important, and then be able to then run those algorithms, whether you create it or you acquire it or borrow it. Be able to then run it with your own data set so that you can compare it and tune it to your environment. So it's not just as easy as I have an algorithm, I need to go test it. You actually have to have, I think, a pretty solid group of data scientists who can help you with the clinical analytics and really understanding the data that goes into helping localize that specific algorithm.
Right. That makes sense. George, did you have a question?
Yeah, Dr. Bart, I had one question. Just so at the top, you were talking about, you're speaking with your CEO, and this discussion around an organization could spend $50-100 million or something and not see a huge impact. Can you articulate for this audience, what is the FOMO? Like, if I was a healthcare organization, I just said, I'm going to sit out completely. I'm not buying into the AI hype train. It's a bunch of woo. I'm not interested. What is the driving force that is making people not comfortable with making that decision?
I will tell you, a number of my colleagues, to what you just commented on, George, a number of them are thoughtfully considering being sort of latecomers to this. I think the FDA, for example, the FDA is starting to generate much more commentary around artificial intelligence in healthcare. I think that they will establish a clear set of guidance and guidelines on it, whether it's for something that's locally generated or something that is acquired commercially from a vendor. One of the ways that we've thought about it is, I think there's a difference in artificial intelligence that's leveraged in the healthcare system to improve efficiency and effectiveness in the process of care delivery versus those that might be specifically around guidance for clinical decision support. And we've sort of separated those out. I think we have a high interest in intelligent solutions that really help us improve the efficiency of care delivery processes. You can imagine that everybody's healthcare systems are very, or operating rooms, specifically, operating rooms are a very complex set of, there's physical requirements, large pure personnel requirements, and scheduling and availability. And I think people have done good with traditional scheduling tools, but I think inserting intelligence there in that space could be valuable, very valuable in improving throughput through a limited resource. Where, you know, you look at that for some of the clinical environments like ambulatory care, hospital care, there could be value in that. It is a way of getting comfortable with intelligent solutions in a manner that doesn't directly impact clinical decision about a given patient and potentially change how you think about that clinically. And so I think one is, let's get comfortable with artificial intelligence or intelligent solutions. And maybe the way to do that in healthcare is to do it through operational improvements in efficiency. And then as that occurs, start to get comfortable with some of the algorithms that either your own group may be making within your healthcare system, where I'm fortunate at UPMC to have that, or for those vended types of solutions that you can acquire. One of the earliest vended solutions we acquired was in the stroke imaging space. And that has provided good value to us in improving the speed to decision making on patients, where seconds and minutes are very valuable in potentially improving the outcome. So being thoughtful about where you are willing to sort of dip your toe into those that are directly impacting or potentially impacting clinical decision support.
And then one last topic, and then Jeff, I'll turn it back over to you. So from your perspective, Dr. Bart, the excitement about AI, or you gave some really great examples of where it could have that impact. And the question I have is, from your perspective, is the driving force around, and again, all of healthcare, this is tied together, but is the driving force around this desire to really improve like these outcomes, or this just excitement from a medical standpoint that, oh, wow, we can just provide better care and this can just be a better experience? Like, what is the percentage where that is the driving force from an organization? And like, okay, think of the potential, what this could have. And then what is the percentage which is just brass tacks revenue? Like just efficiency, like the real driver? Is it an even 50-50 split? Or at this point in time, do you think the excitement is more on the, holy crap, you know, we're just struggling, we're in the red, there's these opportunities to, like you said, if we up our scheduling this percentage, you know, we can maybe make this much more, you know, kind of what's the balance from inside an organization like yours?
I think there's sort of potentially three drivers. One is truly, if you have a more efficient healthcare system, you probably have a system that has more effectively managed the cost of care delivery, and therefore financial improvement is an opportunity there. So that's one driver. The other, like the stroke imaging example algorithm I mentioned, that one is trying to have more efficient or improvement in clinical decisions and aiding in that process. And so that's really more a direction in trying to define an improvement in care delivery. And I think that ultimately is going to be a larger component as more of the clinical care side part of healthcare systems becomes more and more comfortable. And I think also there's more oversight and guidance on those types of algorithms used there. And then the third component, and Jeff brought up generative AI at the beginning, which most of us are, you know, think about in the speech conversational space. And the third component there is probably, what are those types of intelligent solutions that might improve the efficiency of a physician or an APP or a specific clinician in the process they're doing? And in that case, it's not necessarily about more efficiency and throughput, but it's potentially decreasing the burden of technology on a clinician in the care delivery process. Because I think one of the things, some of the best technologies, and I'm actually blanking on an example right now, but I mean, are become really invisible in the use of that technology. And I think some of the generative AI in the voice documentation space, where if I'm the physician and Jeff is the patient in front of me, that technology veil or barrier between us starts to dissolve, because the conversation becomes the root of the documentation that I need for the care that I've delivered to Jeff.
You mean like a nuance ambient clinical solutions, Rob? Sorry to interrupt.
Yeah, no. So Nuance Ambient is one of them. There's another company called Bridge that is in that space. But those are the types of solutions where there is a benefit to operational efficiency, but there's also a benefit in decreasing effort, and that may translate into decreasing physician burnout or improving physician wellness, right, in the care delivery process. Because I think a lot of technology has added a little bit of administrative burden to all of us in the care delivery process, and this is a way of eliminating some of that.
I think a little bit is a very kind and generous term for the amount of administrative burden, Rob.
Mm-hmm.
Let me ask you this. One of the things we have talked about, and you mentioned it earlier in one of your answers, is using some of the operational revenue generating efficiency tools of AI to get clinicians more comfortable with helping make diagnostic and treatment decisions. How do you kind of on a either mechanical or logistical basis go about helping clinicians who aren't as comfortable with AI first get comfortable with maybe some of these operational aspects, and then as you think about the stroke application, you talked about getting them comfortable with using them for clinical applications?
So actually, let me just step back from AI for a second in that space, sure, Jeff, because so clinically, I'm a pediatric intensivist, and there are pediatric risk of injury and mortality scores that and algorithms that are very traditional, old school algorithms that I've been using in clinical care for nearly 30 years.
Mm-hmm.
There's a cohort of my colleagues that weren't as adoptive of traditional risk in scores. They, there are people that feel that they don't necessarily add particular value to their ability to deliver care with an individual patient. If you in that realm are traditionally averse to old school inductive sort of logic types of scoring, you're similarly going to be averse to artificial intelligence driven algorithms and scores.
Yeah, that makes sense.
So I think it has to do with, it's not just your comfort and belief in artificial intelligence, but it's also your belief in some of the more traditional algorithms that people have used throughout healthcare in general. I do think that as artificial intelligence becomes more and more of what occurs in daily life, and it's like many things, right? We're going to see it in other aspects of our lives. San Francisco has now got two companies that have the self-driving cars that they've greenlit, right? And so as you start seeing that in other aspects of your life, I do think, and you see it being successful, I think that will also infuse the ability to use artificial intelligence in a much more applicable manner within healthcare. There will be a point, and I don't know if it's not 1 year from now, but there'll be a point 5 or 10 years from now where I think the physicians who embrace and engage and adopt artificial intelligence into how they deliver care, not necessarily how it drives them, maybe in more of a co-pilot type of a process, right? Something that is they bring in and contemplate within their decision making and allow them to either make a decision faster or allow them to have a broader differential diagnosis than they initially would have had themselves. I think you're going to see those physicians thrive and potentially be more successful than those who sort of turn a cold shoulder to that type of technology coming into healthcare. But it's going to take time, and part of that time is developing trust in it.
So you mean in that sense, kind of like a what's referred to sometimes as kind of like freestyle chess, where the combination of augmented AI, augmented intelligence with the clinician, giving them more options as opposed to replacing their diagnosis. In this case, the computer and the human did better on chess than either the human alone or the computer alone.
So I think you captured one of my favorite words, Jeff. It is augmented. I do think it's going to augment the intelligence or augment the efficiency with which a clinical decision can be made. But it will not supersede or replace the human element in it, at least not for a very, very long time.
Right. Well, thank you, Rob. This has been, very, very helpful. I'm sure we'll revisit this and probably ask you back, as I think AI and clinicians' interaction with AI will stay on the radar for quite some time. We appreciate your time, and we appreciate you joining us.
Thank you so much for the time, Jeff, and also you, George.
Good to see you, Rob.
James,
sorry, we get to the social determinants of health question with Dr. Bart, but we should be able to, that is a good one to talk about, and we will have, this is a weekly show, so maybe that's one we'll make a whole topic around.
So George, do you want to introduce the quick hits, and then I'll get to those quickly?
Sure. Okay, so, or did you want to do the just rundown and then we go into the discussion articles, or vice versa?
Yeah, why don't we do the rundown, the quick hits? Yeah. So why don't I just go right into them? So a couple quick articles that have gotten a lot of or areas have got a lot of attention. As everyone knows, or I think everyone knows, the first 10 drugs for Medicare price negotiations have been chosen. The Biden administration and HHS announced the top 10 Medicare drugs for price negotiation in 2026. The companies must now either agree or negotiate with HHS by October 1st, which I think will be a demarcation deadline for a lot of litigation. There's going to be significant litigation on this going forward. I don't expect anything really to happen on this for quite some time. However, you may see some price pressure on some of these drugs, obviously, and some drugs in similar clinical areas because of what's going on here. So I watch this very carefully, but this will take a while to play out. Also, an article from Millman on payer strategies for GLP medications in weight loss, GLP-1 medications. And interesting, the article pointed out almost 70% didn't stay on the therapy for 12 months, resulting in what they calculated to be 25% waste in spend. The employers, I think, are going to really control this discussion. And what I would say is, right now, only 30 to 60% are covering the GLP-1s. And of those, 80% are making that part of a bigger plan. I do think that the GLP-1s are going to find themselves subject to pre-authorization, part of a more holistic weight loss regimen, which is going to include diet and exercise. In addition, there was an interesting article about the Canadian province of Quebec choosing Epic for their EMR and for their health system. It's a $3 billion deal. One of the keys to getting that deal is someone who needed French experience, and Epic had gone live in Belgium. What I do see is I think this is just showing that Epic's continuing to dominate in large deals, and now that's proceeding to the outside the US. And then there's been a huge, the New York Times had an interesting article in it about the huge threat to the budget that has receded, no one's sure why. per person Medicare beneficiary spending has leveled off over the last 10 years, saving $3.9 trillion for the budget. To give you some sense, the Medicare budget cost negotiations on drugs are only saving $100 billion by comparison. The CBO does expect to see this ticking up again, and that will be something we have to watch, particularly as you get high cost treatments like the GLP-1s, and the population ages. One of the people who commented in the article, Sherry Khalid, who is the dean of the Wagner School at NYU, is the dean where I teach adjunct. So we will try to get Sherry on the program to discuss this topic. And with that, George, I will turn it over to you to introduce the first article for our discussion.
Great. So we just have two articles. We're going to go in a little bit more detail here and have a bit of a conversation, then close you out here. Thanks again, everyone, for joining us. So the first one we wanted to chat about was this last week in Health Affairs. There was an article about the FTC's increasing focus on protecting health data. So the salient points, just to call out to the group, is that there is a health breach notification rule that is enforced by the FTC and has actually existed since 2009. It outlines how an organization has to notify various parties when there is a breach of health data, usually of impacting over 500 individuals. The limitation here traditionally was that it defined traditional healthcare organizations as defined by HIPAA, which is really health plans, clearinghouses, and then healthcare providers. And obviously from 2009 to 2023, the types of organizations which are owning, persisting, making use of healthcare data has expanded drastically, where those three organizing categories are really not an effective definition. So this rule expands who is required to adhere to this notification rule, and for patient data security, to really anyone who is persisting in making use of healthcare data, and primarily healthcare app developers or digital health app solutions. So clarifying this rule, it expands who needs to adhere to these rules about if there is a breach or if information is made available in a way that it shouldn't have been, what types of organizations fall under this jurisdiction. It also expands what types of data is called out as healthcare data. It includes a couple interesting examples, such as just your location data and then recent purchase history, if it can be used to correlate with healthcare data. And then it expands the definition from a breach of just strictly a cybersecurity hack to also just be unauthorized disclosures. So I think this is really important to call out because the industry has evolved so much, where there are so many different organizations who have access to and are using, persisting, leveraging healthcare data in a variety of ways. Only looking at healthcare providers, health plans, and clearinghouses is totally ineffective. So I think including a broader group makes sense. And then I think the other thing to call out here is that this rule has existed since 2009, but it was never enforced. And rules that aren't enforced aren't necessarily followed. So in 2023, there were the first two examples of the FTC actually bringing, suits against two companies who, didn't follow this health breach notification rule. And generally, I think that that's good. I think that regulations for patient data safety and security should be enforced and should have teeth to them to make sure that organizations, cross their T's, dot their I's, and are doing the best thing that they can. So, Jeff, do you have anything more to add to this?
I think that was pretty thorough, George, but I will say, I think, your comment on the enforcement is key. I think you're going to see more broad enforcement in terms of, data blocking, in terms of breaches, in terms of interoperability. And I do think it's rolling out. Well, it was very similar to this in the sense that, it was very limited, very light enforcement. And then you had a couple of very high profile cases where they put people on notice. And I do think you'll see a similar pattern, and in particular with the data breach notification rule, you'll start to see more frequent and more high-profile notices, and then I think you'll start to see the same trajectory with information blocking and other rules.
And then my last comment on this is that I would just encourage folks that sometimes, if you hear about a breach, it's very easy to jump to the conclusion of just negligence or malicious act. The reality is that keeping data safe is a constant, ongoing struggle that organizations devote a ton of resources and energy to, and no one is perfect in it. Like, when you can have organization like American Express or FedEx or just, they have more resources than God and they can still have issues with cybersecurity. Healthcare, a lot of these organizations are doing everything they can. And sometimes when a breach happens, it doesn't mean that that organization should be completely written off. Obviously, you should look into the case of the details and what exactly was happening. But I just think I have some empathy for organizations just because everyone is doing their best. Like that is why it is cybersecurity is, the good guys and the bad guys continually going back and forth. It's rarely just like abject negligence or malicious actions. So our final article we want to go into more details is around CEO musical chairs. So in healthcare this week, we had some big news that came out. So the first was that the CEO of Walgreens, Rosalind Brewster, is stepping down after 3 years at the helm. And then also the CEO of One Medical, Amir Dan Rubin, is stepping down after 1 year of being acquired by Amazon. So this is kind of interesting, right? Everyone can have a different perspective on what this means. Is it doom and gloom? Is it just normal business turnover? My perspective, I'm going to focus on the One Medical, and I'm interested in Jeff's take on Walgreens and One Medical as well. But when I think about Amir Dan Rubin leaving One Medical just 1 year after being acquired by Amazon, I don't think it's necessarily a bad sign. I think it's very often that after an acquisition, there is a buyout period, and it's very often that someone who is from an entrepreneurial background or from a startup space is not going to stick around a large organization that long. Although it is interesting, Amazon's other big healthcare acquisition, PillPack, those founders hung out for 4 years. So, maybe you could read into that. But I would say it's not necessarily means that they regret the One Medical acquisition. I think it might just be normal business operations. As far as the Walgreens, Jeff, you're a lot more tuned into, kind of the macro trends and that level of things. So curious your take on these two CEOs stepping down, what it means for healthcare.
So first on Walgreens, I was, actually quite surprised that Roz Brewer left. She's only been there for 3 years. And this was, a big turnaround. She was handpicked by the prior CEO who had been there quite a number of years. I'd say a couple of things. The stock is off 50%. CVS stock is off significantly, as is, issues at Rite Aid. But I think it's the difficulty. It shows the difficulty of shifting large volumes into value-based care. They had the acquisition of Village MD before she got there. They acquired Summit for almost $9 billion. They had CareCentrix and others. So I think it's a difficulty. On Amir Dan Rubin, I have a little bit different take. Two things. One is he's coming into Amazon, which really doesn't have a healthcare background. I'm a little bit surprised he's leaving so soon. He also wasn't quite as entrepreneurial. He had been at Stanford. So I'm a little surprised. To me, it's indicating that maybe it's not getting the traction quite they thought it had in terms of One Medical. I mean, they had a 30% discount on the 1 year membership on Prime Day, which is a pretty decent amount. So I think that's one of the issues. The other thing I think it shows, both of these things show, is the difficulty of integrating acquisitions into silos in healthcare. Healthcare is very siloed, and a very interesting thing that Warren Buffett said years ago when the J.P. Morgan, Berkshire Hathaway, Amazon partnership failed was there's bias in healthcare, and everyone thinks there's a problem, just not with their part of the system. And so there's there are I think enough problems to go around, and I think that's kind of what you're seeing is. Roz Brewer came from a retail background, saw some of the problems, made the acquisitions, and didn't quite sense how to get these acquisitions integrated. And they're going to go hire someone with a very deep healthcare background. Amir Dan Rubin, I think, saw some of the problems outside of maybe the provider space, but didn't see what it might take to deliver primary care at scale in a value-based method for someone like Amazon.
Super insightful. Yeah, I think the other thing I would just add to it is that, in the macroeconomic state of things, everyone's book of business is down. Everything that was acquired a couple years back was at the peak, and all those numbers and marks are looking a little bit rough. So people who are in charge of leadership at that, it's kind of normal to shift things as everyone is looking for answers to improve some of that stuff. So Interesting. We'll keep an eye on it, see how One Medical evolves, see what Walgreens' next move is. They both have, long-term folks moving into those positions that you can read about. Jeff, you want to wrap us up?
Sure. So, as I said, I am the founder and principal of Healthcare Strategy Bullpen. We really try to help you figure out how to use innovation to, make your case in healthcare, whether it is as a startup looking to sell into healthcare or whether it's as a payer or provider looking to figure out how to use the right healthcare. We urge you to, please sign up for our blog. If you have any questions or comments, please feel free to send us an email to diagnosinghealthtech@healthcarebullpen.com. But please join us for future podcasts, and please feel free to send us your thoughts. And we look forward to having you with us next week. And with that, I'll turn it back over to you, George.
Thanks so much, Jeff. So just a reminder, Diagnosing Health Tech is sponsored by Redox. Redox is an organization that helps healthcare organizations, health plans, and digital health product teams manage and integrate healthcare data. We simplify data exchange to a single API experience, which allows product teams to focus on composing the best experiences for end users. And we have a number of products that also help with onboarding to cloud environments such as Google Cloud, Microsoft Azure, AWS, and then even patient identity management solutions sponsored by Verado. So if you need help achieving your healthcare data management integration needs, Redox is here for you. Check us out. So to close this out, just a reminder, the best way to stay in the loop is to hit the green button below, which allows you to subscribe for updates from Diagnosing Health Tech. A reminder, this is a weekly show that Jeff hosts with a rotating cast of hosts like myself and then esteemed guests. Next week, we're going to have Tom Lowry, the author of Hacking Healthcare, about how to leverage AI and the cloud in healthcare. An amazing guest. Tom Lowry is a top 20 AI voices to watch. Hacking Healthcare is one of the must reads if you're in health tech or getting into health tech. So just going to be a really incredible conversation. We have Kaylin Gigot from our organization will be co-hosting from Redox with Jeff, and that is one you are not going to want to miss. So thank you everybody for joining us today. Remember, weekly show, we'll be back with more awesome guests, and hope you have a great day. Jeff, it was great to see you.
Nice to see you too, George. Everybody have a good week.